The Senate Committee on Health, Education, Labor, and Pensions will please come to order. You know, I talk to a lot of folks, and when you speak to people right now in Louisiana or across the country, the ability to afford things is the biggest issue. One example is healthcare, way too expensive. So premiums are climbing, and even those with coverage face thousands of dollars of out-of-pocket costs when they seek care. And I'll speak to my colleagues in the Senate, and they'll say, oh, this is a great policy. I said, man, it's got $3,000 deductible. Do you think the average family has $3,000 just to sit there and when their child has an earache, go get it cared for? And the answer is no. They don't have that kind of money in order to do that. So I have found as a physician practicing for many years that when you give the patient the power of knowing what the price is, and the patient the power of controlling her healthcare dollar, then prices tend to come down. And so we have to address not just the cost of health insurance, but the cost you pay before the insurance kicks in. And that's what we're really going to look for. Now, one example I'll tell you, I was once in DC. We have a crawfish bowl every year. You're all welcome when you're in DC. And there's a woman who found me on the street. She goes, hey, you're Dr. Cassidy. I said, yes, I am. I'm from Texas. Well, that's great, but you're not my voter. And she goes, I saw your YouTube talking about price transparency and how if I paid cash and called the person doing the procedure, doing the x-ray, I could get a better price. And so they ordered an MRI for my son. It was going to cost $2,000 for his shoulder. I called the MRI place and I said, how much if I pay cash? And they said, oh, you pay cash, it's not $2,000, it's $600. Well, her deductible was $2,000, so she already saved money. And she goes, what if I pay you with cash and not a credit card? Oh, we'll give you another discount if you don't pay us with a credit card. So the fact is that she had the power of controlling the healthcare dollar, but she was also, through her own initiative, knew the power of price transparency. And she saved lots and lots of money. So that's our goal. So I've introduced a bill we call the MVP plan, Money and Value for Patients, the MVB plan. And it does exactly that. Using the tax code, it would forward money into an account that the patient would control. I always use the feminine because women rule the world, of course, and they certainly rule the healthcare expenditure for the average family. And so you send it to the mama's account, and she controls that dollar. Now, if it goes to the insurance company, we know that 20% goes for overhead and for profit. That's just a given. Instead, 100% goes for the care that she knows she needs. And it puts her in control of the money that she would use to pay for her child's health care. So imagine someone in Lafayette, her daughter has an earache. She could pull out her phone and she could say, urgent care center near me. Which has the best price? Now, we're going to team this, by the way, with tools being developed that are able to scrape and find out what the actual cash price is for various places. This is being developed. I've seen this happening now. It's being used now. So she would say, urgent care center near me, which has the best price for a routine visit for an earache? It would pop up. It would say, if you go down the street to the left, there's going to be a place they're going to charge $50. If you go down the street further, it's going to cost you $150. She is going to be able to shop for that care for her daughter as easily as she might shop for the best price for gasoline. Now, this is a real situation. When I practiced medicine in a hospital for the uninsured and the poorly insured. But it doesn't have to be there. You can see examples of the mother trying to balance the cost of care for her family versus other things she had to pay for. This is a real life example. I say if you make healthcare more affordable, you can also make gasoline and groceries more affordable because it's the same pot of money moving between the three. So let's make this more affordable, and that will make the other two more affordable too. By the way, instead of families scrambling to pay bills, this makes life better for them. Most families, 60% of families will not have over $2,000 of healthcare expenditures in a given year. In our plan, we think that a family of four would have about $2,000. That would take care of 60% of the out of pocket. And I've got insurance people on here, and they would say, wait a second, if the first $2,000 is covered, then probably I'd be selling them a policy with a higher touch point, which means the premium would be as much as 10% lower. So we're benefiting on the upfront cost, we're benefiting on the expenditure as regards the premium. So over time, of course, the health savings account accumulates if you don't spend it, and that way it eventually covers the entirety of that gap. Now, we can also get patients access to more affordable drugs, and we're hearing about affordable drugs, by cutting that bureaucratic red tape that slows the approval of cheaper generics and biosimilars for the drugs that you infuse. By the way, my MVP agenda builds off of what Republicans are already doing. Earlier this year, a PBM reform bill that I negotiated, President Trump signed it into law, and this directly lowers the amount patients pay at the pharmacy counter. And his administration came and spoke to us about helping them write legislation for Trump Rx, which will allow patients to buy drugs directly and transparently, cutting out bureaucracy and hidden fees. So by putting money in the patient's pocket, delivering price transparency, the MVP agenda delivers what people in Louisiana have asked for, healthcare they can afford with power in their hands. Now, I thank the witnesses for being here. I will introduce each as she or he does their testimony. We're joined first by Ronell Nolan, founder, president, and CEO of Health Agents of America, a national nonprofit trade association representing independent health insurance agents and brokers in all 50 states. She's a leading advocate for ACA enrollees and agents, focusing on protecting consumers' access to licensed professionals, reducing fraud within the marketplace, ensuring access to affordable plan options that fit their unique needs, and strengthening accountability within the ACA markets. Thank you, Ms. Nolan. Please.
Senator Cassidy, thank you so much for the opportunity to be here today. I'm here today to bring you a frontline perspective, the reality of healthcare affordability from the agents who sit across from the kitchen table from American families every single day. Let me be very direct. Healthcare is not just expensive. For many Americans, it's becoming unaffordable, even with insurance. And agents and brokers are the ones delivering the message. Once we are explaining to the family why the premium went up again, why their deductible is so high that they can't realistically use the coverage, why their doctor is no longer in the network, and why their plan they worked for and worked with last year does not exist. During this past open enrollment, we saw something very concerning. For the first time in a significant way, families who wanted coverage simply could not afford the coverage and couldn't purchase it. We had individuals making difficult decisions to go uninsured, not because they didn't value coverage, but because the cost was beyond their reach. We saw parents making heartbreaking decisions, choosing to cover their children and going without coverage themselves. The crisis is real. And let's talk about fraud. The fraud is loud through a broke system. The federal marketplace has a huge hole which allows bad entities to come in and change Americans from one plan to another without their knowledge. This plan could be closed very simply by CMS implementing a two-factor authentication. We ask for that win. And I'd like to share an example from Louisiana. Husband and wife were reviewing their options during open enrollment. The husband had just had a transplant. He was on life-saving medication, and coverage just wasn't optional. Their monthly premium went from $1,000 to $3,000 a month, with no meaningful alternative available for them. They had no choice. They looked to borrow money, start a GoFundMe. They went to their church just to afford the premium, not even talking about the sky-high deductible. This is not sustainable, and it is happening. Agents are not the problem. We are the translators of a system that has become so complex and so costly, the average American cannot navigate this alone. When affordability breaks down, consequences are real. People delay care, They skip medications. They choose between coverage and groceries, as the senator said. This is not a coverage issue. This is an affordability crisis. From our perspective, there are 3 drivers that must be addressed. First, rising premiums without corresponding value. Consumers are paying more, but they do not feel more protected. In many cases, they are paying for coverage they can't even use. Secondly, the instability in offerings of networks. Constant changes, the confusion, disruption in care, and the erosion in the trust in the system. And third, barriers to professional guidance. When agents are removed from the process, whether it's through reduced commissions, administrative burdens, platform restrictions, consumers lose access to the one resource that makes and helps them with those informed decisions. So let me be clear with this point. When you remove the agent, you do not simplify the system. You leave the consumer alone in it. Agents don't sell policies. We advocate, we educate, and we help the consumer remain covered and protected over time. Senator Cassidy, we sincerely appreciate your leadership, particularly your work with the greater transparency, accountability to healthcare. Those efforts matter, and we strongly support continued progress in that direction. Transparency is a critical step towards restoring fraud, trust, and helping consumers understand the true cost of care and coverage. Affordability is not just the price of premium. It's about whether the coverage works when the people need it. It's about access, stability, and trust. And right now, Americans are losing all 3. If we want to fix the healthcare system affordability in this country, we must continue to focus on transparency, accountability, and real-world impact on the people that we serve. Coverage should not depend on whether someone can fundraise to stay alive. I sincerely thank you for your time.
Thank you, Ronell. We're next joined by Debbie Rao, owner of the Coffee Connection and Acadian Coffee Roasters, which I just learned does organic coffee.
Yes.
And she looked around and said, there's no coffee here. So, memo to staff. She can supply it at a discount. As a small business owner, she is passionate about serving her community and deeply values improving the health of people in our state. So thank you for joining us.
Yes, it's a pleasure. Thank you, Senator Cassidy, for the opportunity to speak here today. I am going to come at this in a personal way. Healthcare is often discussed in terms of percentages and billions of dollars. I am here to speak about those numbers and what they mean in real life, the human cost behind them. I'm going to talk about the reality of survival. This is my personal account. In 2017, I suffered a heart attack. In that moment, my only concern was survival. I spent 4 days in intensive care unit under constant monitoring and receiving the kind of life-saving care our medical system is known for. At the time, I could only afford the catastrophic insurance. I could not afford healthcare coverage. But the moment I left the hospital, that survival came with a devastating financial consequence. The total charges when I was discharged was $101,000. My insurance paid $5,300, so my responsibility was $95,700. For a medical emergency that I could not prevent, I was left responsible for nearly the entire cost. I could not afford the coverage insurance, so I could only take what I could afford at the time. So the mathematical impossibility of care. I'm going to ask, how is any working American expected to absorb $95,000 in a medical bill? This was not simply a bill. It represents the cost of a home, my years of retirement, and my savings. It is placed on individuals at the most vulnerable when they are still recovering physically and emotionally. The stress caused by this level of a financial burden is not abstract. It directly impacts health outcomes. In my case, the financial strain became a continued threat to my very heart condition that I had just survived. There is a systematic failure in billing and coverage. My experience reflects that. The illusion of coverage. Possessing insurance does not guarantee meaningful protection. When less than 6% of critical ICU stay is covered, the promise of insurance is fundamentally undermined. The charges of approximately $25,000 a day in ICU care are disconnected from financial reality faced by all American families. Patients are effectively placed between providers and insurers, absorbing the financial fallout or disputes over reimbursement. The financial stability becomes collateral damage. I respectfully urge this committee to take meaningful action to ensure that life-saving emergency care is covered at substantial and a consistent level. No insured patient should ever face catastrophic debt due to gaps between provider charges and insurance payment. Yes, my doctors did save my life, but the financial aftermath nearly destroyed my stability. No American should have to consider in the middle of a medical emergency whether seeking health care will lead to a financial ruin. What I have personally experienced has changed my outlook drastically. It has shaped how I view my health and the importance of what we consume daily. This is not just a belief, but it's what I live out and I teach every day. I have dedicated myself to consistently reading labels and being intentional about everything that I do. I do choose to serve in my restaurant, in my coffee shop, in my cafes, all clean products, because I do feel that that is a start. I firmly believe that much of our healthcare can begin with greater awareness of being intentional in all we do. This is not a trend, but it is a necessity. Thank you, Senator, for your time and consideration.
Thank you for powerful testimony. Ms. Hoop. Oh, I'm supposed to introduce you first. I'm sorry. Excuse me. I was so intent on listening to the testimony. We're joined now by Kathy Wu, the CEO of the Pontchartrain Cancer Center, a treatment and cancer prevention center specializing in blood disorders and providing compassionate care to patients navigating difficult diagnoses. She's a leader in healthcare as she serves on several oncologic boards, including those involved nationwide. She's a speech pathologist who earned a degree from LSU and helps patients rehabilitate from cancer treatments. Thank you for being here, please.
Good morning, Chairman Cassidy, and thank you for the opportunity to speak on healthcare affordability. First, I'd like to acknowledge your leadership in the work of the Health Committee on Pharmacy Benefit Manager Reform and 340B accountability. These issues are central to whether patients can access timely, affordable care. And as you've heard already today, our healthcare system is facing a deepening affordability crisis. Patients, employers, and taxpayers are all paying more, while care is harder to access and disconnected from the vital physician-patient relationship. And this problem is simply not cost. It's federal policy that has allowed marketplace to consolidate, distort prices, and reward institutional power over patient-centered care. If I had to, identify the root cause in one word, it would be consolidation. Hospitals have merged into dominant regional systems. Insurers have vertically integrated with PBMs, pharmacies, and physician groups. Independent community-based practices, including community oncology, are being pushed out by payment rules that favor large systems. This consolidation has raised prices, limited patient choice, and does not reliably improve quality. Independent community oncology like Pontchartrain Cancer Center, we strive every day to deliver high-quality cancer care close to where our patients live in our very own communities. But when those practices close or are acquired, patients are often shifted into hospital outpatient departments, where the same drugs and services can cost far more. So if I may be so bold, I would like to see Congress first implement site-neutral payment reform, so Medicare pays the same amount for the same service, regardless of the site of care of delivery. Current policy often pays more because of ownership, not clinical complexity. Broader site-neutral reform could save taxpayers, employers, and patients billions over time. Second, I would like to see Congress, with your leadership, sir, continue your work on 340B, the 340B drug pricing program. This vital program was created to support safety net care, but has grown far beyond its original purpose. Hospitals are not required to pass those 340B savings directly to patients, and 340B revenue can fuel hospital expansion, physician practice acquisition, and movement of cancer care into more expensive settings. I appreciate that you in this committee have begun asking the hard questions about whether 340B is serving patients as intended. Congress should build on that oversight by requiring transparency, patient eligibility standards, charity care obligations, and safeguards to ensure 340B benefits patients in need rather than financing consolidation. And third, I would ask Congress to continue addressing insurer and PBM consolidation. The largest PBMs are no longer neutral administrators. They are part of vertically integrated corporations that own insurers, specialty pharmacies, mail order pharmacies, and in some cases, physicians and drug manufacturers. The three largest PBMs control access to 80% of the prescriptions in the United States. This gives them enormous power over formularies, reimbursement, prior authorization, and pharmacy choice. For cancer patients, these practices can delay or deny treatment. At Pontchartrain Cancer Center, when we write a prescription and can dispense it through our pharmacy, we can often obtain prior authorization and start a patient on therapy in 24 to 48 hours. When we must use a PBM-owned specialty pharmacy, we see an average delay of 5 to 15 business days. The son and daughter of one of our patients accompanied me to the Hill during one of my first visits to your office, where we had discussed how their mother experienced a 35-day delay and passed away before being able to try her physician-prescribed medication. We had that medication in our pharmacy, but we were not allowed to dispense it because her plan's PBM required use of their internal specialty pharmacy, but the insurer would not authorize it. We will never know if that drug would have helped her cancer, but what it certainly did was delay that patient and her family of hope. And delays in cancer treatment are not harmless. They impact families, they impact patients, and they impact survival. Congress should continue its work on PBM transparency, prohibit spread pricing, patient steering, which does exist, delink PBM compensation from drug prices, prevent mandatory use of affiliated pharmacies, ensure that cancer prior authorization decisions are made timely and reviewed by physicians with appropriate specialty expertise. Patients do not experience healthcare in silos. They experience it as a bill they cannot afford, a prescription they cannot fill, or a treatment that is delayed by prior authorization or because their physician is no longer in business. Chairman Cassidy, I appreciate your leadership and the Health Committee's work on PBM and 340B reform. These reforms are about whether patients can get their care their physicians prescribe when they need it. And I urge this committee and Congress to continue its work on healthcare affordability, not to protect institutions, but to protect patients. Thank you.
Thank you. Next, we're joined with, and I feel like I should almost recuse myself, by my pharmacist. So maybe a little bit of a conflict of interest as I sit here and praise him. But TJ Woodard is the owner of Prescriptions to Go, that's GEAUX, a local independent pharmacy with 2 locations in Baton Rouge. He's passionate about delivering healthcare services to his community. During the pandemic, for example, set up the immunization practice and did very well with that. And by the way, whenever I am talked to by independent pharmacists across the country, they all happen to know TJ. So TJ, I'm not quite sure what it is, man, but you've done a good job of connecting. Please.
Thank you, Senator Cassidy and Ms. Zub. Thank you. You couldn't have set this up any better for me. So
Talk about it.
I'll try to be brief. It's tough with the list of grievances that we need to address. But Chairman Cassidy, thank you for coming home to Louisiana and for the opportunity to testify about the skyrocketing cost of health care. My name is TJ Woodard, and my wife Amy and I are both pharmacists who own and operate 2 independent pharmacies in Baton Rouge, Prescriptions to Go. I am uniquely situated in this discussion as a patient, a provider, and an employer. I've seen the cost of care increase exponentially while quality and access have decreased. Like many providers, I spend way too much time navigating the unnecessarily complicated pharmacy benefits model. Time that would be better spent on patient care or efficiently running my small business. The bad news is this is a universal problem that affects every community in America and is an enormous expense to families, employers, states, and the federal government. The good news is there's a tremendous opportunity to right the ship. In pharmacy, we love acronyms. There's AWP, NADAC, DIR, GER, PSAO, and numerous others. I won't bore you by explaining these things that contribute to the unnecessarily complicated model that I just mentioned. Today, the only acronym that matters is PBM, or Pharmacy Benefit Managers. They are the single biggest problem in the prescription supply chain and a major contributing factor to the explosion of costs in healthcare in America. To be fair, not all PBMs are bad actors, and the concept behind their creation was somewhat valid, to streamline the process for efficiency and cost savings. As Ms. Zub mentioned, that's certainly not what they've evolved into today. The big 3, CVS Health, United Optum, and Express Scripts Cigna, control 80% of the drug market. They are vertically integrated monopolies who dictate every aspect of patient care in America, and it is almost never for better care or lower costs. Good PBMs are those that simply streamline the process, are transparent, and charge a fee for their service. Think of using a credit card at a large department store to buy an assortment of products. They provide a valuable service and are paid a nominal fee for doing so. Unfortunately, the bad PBMs are the overwhelming majority of the market, and their offenses are too numerous for my introduction. Not only are they driving up costs and negatively affecting patient care, they are putting pharmacies out of business at an alarming rate. This is a real threat to access for millions of Americans, and it isn't just independent pharmacies. Ask Rite Aid, Winn-Dixie, or Target. This is truly a bipartisan issue that affects every community and many struggling small business pharmacies in each of your communities. Not only can we put healthcare back where it belongs, in the hands of patients and their providers, we can do it at an enormous cost savings, which will make healthcare affordable again. I find it best to explain how devastating their behavior is by listing some of these activities and giving specific examples. Taken individually, they're obviously unfair trade practices. Taken together, they've created a healthcare climate that is unsustainable for most independent pharmacies in America. If you don't believe me, ask any independent pharmacy in your state. Vertical integration. If I had to rank the PBM's activities, this would be the most concerning. I worked at CVS when the merger with Caremark happened, and I remember vividly that there would be a firewall between the 2 companies. Today, this is laughable, but it's much worse than we could have ever imagined. The big three PBMs that I mentioned are all vertically integrated and control an enormous percentage of the overall healthcare market. United Health Group generates more revenue than Ford and General Motors combined. The specific part of the vertical integration that is most troubling is that they are both the PBM and the pharmacy. This creates an obvious conflict of interest. When I submit claims for a payment to a PBM that also owns a pharmacy that directly competes with mine, in what world will we allow someone's direct competitor to dictate their payment terms and perform invasive on-site audits? I'm happy to elaborate on this concern, but in short, a company should be a PBM or a pharmacy, but not both. We've seen in Arkansas, Louisiana, and now Tennessee that they will go to extreme lengths to prevent this from happening. They've repeated the claim that if their vertical integration is prohibited, they will be forced to close pharmacies, leaving pharmacy deserts. This is quite telling that they would choose to close the pharmacies that often provide critical life-saving care to keep the PBM. The PBM is obviously the more profitable segment of their business. Steering. As I mentioned, we must submit patient health information to the PBM to process the claim. The PBMs often use this HIPAA-protected information to market to their competitors' patients and incentivize the use of their own pharmacies. This is specifically prevented in some states, including Louisiana, but they do it anyway, often under the guise of ERISA preemption, which takes me to another common tool they use, ERISA preemption. We have passed many good laws in Louisiana, but our insurance commissioner can't enforce many of them because they are prevented by overriding federal law. The intent behind ERISA was sound, but is now being used as something of a get-out-of-jail-free card by the PBMs. I suggest it should be reviewed and adjusted to fit the current landscape, which has changed significantly in the last 50 years. If it isn't, soon, seniors with Medicare Advantage plans will have a pretty card in their wallet that no pharmacy or doctor can afford to take. The Medicare Advantage plans are an enormously overinflated cost to the federal government and an enormous driver of profit for the PBMs, which is why every other daytime commercial is an NFL legend selling you on their plan. This is a segue to another topic that I'd like to bring to your attention, auditing TRICARE. TRICARE via Express Scripts provides pharmacy benefits to nearly 10 million active duty military personnel, retirees, and their beneficiaries. Express Scripts has administered the program for years and to my knowledge has never been audited. This is concerning and I think potentially offers an enormous cost-saving opportunity for the government payer of this program. Not only does TRICARE prevent many independent pharmacies from participating in their network, but we also know they bill the federal government significantly more for some drugs than they're paying our pharmacies. We've seen Express Scripts pay itself over $3,000 for ondansetron, a common anti-nausea medication that should cost about $20. This should be audited and investigated. After preventing vertical integration, the second most important step that should be taken is delinking. This is essentially delinking a PBM's compensation from the price of the drug. This is a perverse incentive that often leads to a much more costly drug being placed on a PBM's formulary, and it quite clearly is baked into the overall cost of the medication. If a manufacturer must pay a rebate, which would be called a kickback in any other situation, to be included on the PBM's formulary, this will necessarily increase the cost of that medication. This defies logic other than it is a major profit driver for PBMs and the manufacturer must pay a sort of sin tax to ensure their drug is covered in the market. For the sake of brevity, I'll stop there and simply list some numerous other PBM activities that stifle competition and a fair market and undoubtedly drive up the cost of healthcare. Spread pricing, steering, audits, GPOs or rebate aggregators, prior authorizations, specialty drugs and pharmacies, predatory contracts, closed networks, and below-cost reimbursements. In a world that is unfortunately bitterly divided, there is a real opportunity in PBM reform. It is truly a bipartisan issue that affects every demographic in every community in America. If we really want to address the skyrocketing cost of healthcare, we must address the runaway trains that some of the PBMs have become. We should demand a free and fair market where costs go down and quality goes up. Breaking up their vertically integrated monopolies and delinking their compensation from the cost of the medication are two things that would show immediate results. I'm happy to answer any questions and provide any specific examples. I represent myself and nearly 20,000 other independent pharmacies in America that are in real danger of being driven out of business by a few but very powerful bad actor PBMs. We are begging you for help. We're simply asking for a level playing field and a chance to run our small businesses and take care of our communities. Thank you.
Thank you all. Now, this is a little bit of a different sort of a committee hearing in the sense that normally the committee members sit on the dais and those who are testifying testify to the dais. We're all here on the dais. So I'm going to, if you will, kind of set the stage and allow more free-flowing conversation. Because as TJ said, Kathy set him up beautifully. But I think as TJ is speaking about addressing the high cost of insurance and the component the drugs play, you two would certainly feature into that. So if you will, I'm going to integrate this. But that said, after saying I'm going to integrate it, now I'm going to separate it. You two spoke about prescription drugs. And specifically those things that would inflate the cost of the prescription drugs over and above that which the manufacturer would be charging. Whatever they're charging, you're both acknowledging that there is a premium we're paying way above that sometimes because of artificial policies, if you will. I think I summarized what you say, almost collusion or antitrust activities. Now, Ronell and Debbie are speaking, though, of the health policy kind of in total. And I think, Ronell, I think I can safely say that you're about how do you allow the consumer to have access to the most information by which she can make the best choice, and the key role that a agent would play in that. I get that. I once tried to pick a Medicare Advantage program for my wife, not to say that she's eligible, it was just a theoretical exercise. And you know, I think about this all the time. Finally, I said, baby, call a broker, you know what I'm saying, for your theoretical exercise, because, you know, I just can't figure this out. And that's on a dashboard specifically made theoretically to be consumer friendly. And Debbie, you spoke about the real life experience. So let me start with you. Your catastrophic policy only paid $5,300.
Correct.
Now, how did that happen? Catastrophic is supposed to pay everything above a certain point.
Yes. That is the insurance, that is what I chose, that when it was all said and done, that is what they paid. I went back and forth, I talked to them, I submitted medical records upon medical records. I talked, I called, I did everything I could, and that is all they paid.
Now, that was after the Affordable Care Act passed, and so theoretically in the Affordable Care Act, policies that, you know, were fig leaf policies were banned, but nonetheless, you ended up with a fig leaf policy unbeknownst to you. Is that
Oh,
fair?
absolutely, yes.
Okay, so that aspect of the Affordable Care Act either poorly enforced or didn't work. Now, I will say that now I don't know if one of the reasons they didn't pay was because your hospital was not in network. Was that one of the issues?
No, sir. The hospital was in network. And this is what I went back and forth about, was at first they wanted to say it wasn't, you know, life-threatening because there was no blockage. There was the record stated, but it was a heart attack. And so they argued back and forth, and, you know, but it was in network.
No,
It was in network.
I'm pleased to say that signed into law, I think in 2020, was the No Surprises Act, which I negotiated, which now says that if the patient goes to a hospital, whether in network or not, with something that a reasonable person would deem an emergency, that it would be covered as if an in-network expense.
Mm-hmm.
And it was precisely because of human stories like yours, where someone would go to an in-network hospital, but a piece of machinery would be out of network,
Mm-hmm.
or they were contracting for EKG services, and that was out of network. And they were getting these huge bills.
Yes.
I remember being in a press conference with President Trump and a fellow from Austin, Texas. He had gone into the hospital, came out with a $100,000 bill, but he thought he had an MI, a myocardial infarction, a heart attack.
Mm-hmm.
It's just crazy.
Mm-hmm.
So the No Surprises Act ends that. So I'm pleased to say, for one aspect of what you're speaking of, that they were disputing that this was something they should pay for, that has been addressed.
Good.
And there are phone numbers which we can get on both the federal and state level that if someone has a no surprises, if someone has a surprise medical bill, that they can call one of these numbers and have an ombudsman intervene on their behalf. I'm told that this prevents 1 million surprise medical bills per month.
That's wonderful.
So we're making progress on that, even if we still don't have coffee. You see what I'm saying? This. But I also applaud you for saying what you were saying about being intentional in terms of how you live your life in order to improve your health.
Yes, that is a must.
It is a must.
That changed my whole outlook on everything, is to be intentional about everything I consume, the drugs that are prescribed to me. I'm very intentional about that. And it shows in my coffee shop, in my restaurant, in my coffee, and my roastery, everything I do. It does show that.
Well,
We're intentional.
that's a nice.
Education is everything.
Education is everything. And so that kind of goes into Ms. Nolan. Because Ronell, I once had 2 people I contacted when I was still practicing medicine. And one called me up and she said, I have a health savings account. My cardiologist just ordered a liver scan. You're my liver doctor. Do I need the liver scan? If I do, I'll pay for it, but if not, I won't. And I said, you do not need the liver scan. And she saved the money. She was quite intentional. There was another person, well, not my patient, but someone who was just wealthy, wealthy. And she goes, I just pay for the gold-plated insurance policy, and I don't ask questions. Whatever is ordered, I get. Now, that's fine. That's a choice. She had the money, so I'm not at all criticizing that. But for most people, they don't have that luxury. So what's in there is empowering the patient's intentionality to be effective. Does that make sense? Now, as an agent, how can we do that?
I think one thing that's very important and gets misconstrued on every level is that every American is different, and you just described that. Everybody needs something different, and that's kind of where we play a role, is knowing, the family, what drugs are you on, what doctors do you have, what is your income, everything that you need to help them find those plans that are best for them. And I think that's important, especially when Congress starts deciding what Americans need, because I don't think Congress knows what we need. I think Americans know what they need, and I think that's important, that the lady with a lot of money, if she wants to do her thing, she can do her thing, but the person who really doesn't have the money can ask the questions, and she knew where to go. Sometimes they ask their agents. Many times I send them to your office, because you guys have a staff that helps them, or whatever state that they're in. So it's important that we have options.
So a couple things. As I'm asking questions, y'all think of a question that you would ask each other, because the insights each of you bring to the table, and I was interested in how all this fit together. So Kathy's going to have a question for somebody, for example. And so just to brag on her. The other thing, saying how people are different. We were recently, I was speaking to some of my Democratic senator colleagues, and I was telling them, you're thinking that somebody getting a policy with a $4,000 deductible is going to meet their need. Most people don't have $500 in their checking account to pay for needed health care. Debbie, I see you're nodding your head. I think that sounds like it was your experience. Mm-hmm. Yeah, not to mention $100,000.
Yes.
So, Ronell, the agent needs to do a screening, if you will. How much can you afford? But think about the total cost of being insured, not just the cost of insurance. Because if your deductible is here, you're not going to be able to afford that insurance. The money's going to the insurance company. It helps them a lot. But most likely you'll never use it unless you get in a car wreck or have cancer or get in a heart attack. So what is your idea?
It's a very complex decision, because you take the premium and then compare it to different deductibles, and you talk about, what do you foresee? We don't foresee everything, but what do you foresee? Do you go to the doctor a lot? Do you have a lot of, medication? Is it worth you paying a little bit more for a lower deductible? Or when you spread it out on an Excel spreadsheet, it's better to get a higher deductible because you're never gonna touch it.
Okay, so, under my MVP plan, money in your pocket for your out-of-pocket, coupled with, with tools on your phone to give you a sense of where you can get the better deal. Imagine a family of four of $2,000 upfront in their pocket. What, tell me, in my mind, but you confirm, that they could then buy a higher deductible policy, which would be significantly cheaper. Is that true?
Right, if they had the money set aside, and I'm assuming you're talking about like in a HSA, something like that. If they had the money set aside, absolutely, that plays a whole part of the decision that the agent has the conversation with them. Here's this $200, here's, you have this, and here's all the things that are gonna happen to you throughout the year that we know of. How does that play a role? And how does that help you save money on the premium or save money on a deductible?
So let's assume, let me just ask you, you may not be able to tell me this. Let's take a family of four. The parents are 40 years old. Everybody's normal health. And you give them $2,000 into a health savings account. And so now they go from maybe a $2,000 deductible to a $6,000 deductible. How much would that, on average, could you tell me, decrease their premium?
I don't really know exactly. 2 to 6 is gonna be significant.
Like significant mean $500 a year or $2,000 a year?
Maybe half, maybe cut it in half.
Now, wait a second. A family of four I just described could have a premium of $15,000 a year.
Exactly. Yeah,
So
we're
you're
talking a
saying
lot of
that that
money.
would cut their premium down to $7,500?
It could, yes, depending on all the factors. Because remember, you're picking you're talking about a plain plan, $6,000 deductible, 50/50, whatever. But it could have some bells and whistles. What if it has, co-pays in it? I mean, you can't really give a blank answer when all plans are complex and all plans are different. And there's bells and whistles in each one.
But my estimate, frankly, from my chief economist, ChatGPT, was that
I love him.
there'd be about a 10% decrease, but that seems very reasonable to you.
Yeah, absolutely.
And so a 10% decrease, and I'm guessing a family of four would pay about $15,000 a year for a policy, or more than that?
Definitely. I mean, like I said, the two people were 3,000. So family of four, you're gonna hit 10,000.
So first, they're taking care of their out-of-pocket because they have money in their pocket to pay for the out-of-pocket.
Right.
And then they're going to decrease their premium by 10%, in this case, $1,000. So they could be saving $3,000 a year just off the top.
Right. But the concern is, do they have the 3,000 to pay it up front?
Well,
So
that would be the health savings account pre-funded.
Right, but can they use premiums for that? Because you can give me 2,000 all day long, but if I can't afford to buy that premium to use that 2,000, I don't have the plan. And
I
I
get
don't have the
that.
2,000.
Now, right now, federal law does not allow HSA money to be used to pay for a premium, but at least the premium would be less expensive.
Right.
So Kathy, your husband, as my wife says, she's from Alabama, your husband, y'all treat cancer patients. So we've been talking in the kind of theoretical about patients being concerned about cost. By the way, y'all be thinking of questions to ask each other, okay? So how often does somebody come into your office and the cost of treatment, the cost of medications is an issue to be dealt with?
You were going to ask me that. So I actually did that research this week because at Pontchartrain Cancer, the way we do things when people come into our office and need, treatment is, you contact their insurer, you get their benefits plan, and then we develop their treatment plan. And it's what the insurance company will pay and what that patient out of pocket will look like based on their individual plan. And when we started doing this over a decade ago, if it was more than, $25 or $30, we would look for assistance for them. So whether that was manufacturer copays, foundation, free drug, or anything in the PAP programs. Well, we quickly learned that $25 to all of us sitting at this table and in the room looked very different than for the majority of the patients that we saw. So we lowered that to $10. That's been our benchmark for probably 8 years. So I had a feeling you were going to ask me that, and so I spoke to our financial counselors this week. And just to give you a sense of the magnitude, we treat about 1,200 unique patients a year through our infusion center. 43% of those people need some type of financial assistance to afford their care. 43%.
And that's after, theoretically, they've probably exhausted their deductible, because by the time they get to you with a cancer diagnosis, they've seen lots of doctors and had lots of x-rays.
Yes, sir.
And there's still an ongoing need for financial
There
assistance.
is. And then, keep in mind, January 1st and 2nd, when that plan year rolls over, we start all over again.
Now, we are speaking about the individual, the employer. But let me ask you, you said something in your testimony about how the independent doctor's practice is less expensive than that which is owned by an institution. Can you elaborate on that, please?
Sure. Well, I think quite.
Less expensive for who, I guess? Less expensive for?
Well, less expensive for the patient. We don't have the overhead that a large hospital system would. We don't put people
So
on
let me
payment.
stop you.
Yeah.
Let me stop you.
Go ahead.
So let's imagine Debbie has to see somebody whose practice is owned by a hospital versus someone who's independent. Are you telling me, and this is not true of Debbie, let's go back to my theoretical wife. Let's assume she's on
Poor
Medicare.
Laura. She's been moved into the theoretical realm.
Let's assume somebody who's on Medicare.
Yep.
So I think you're telling me that someone on Medicare who goes to practice owned by a hospital will pay more out of pocket than that same Medicare patient who goes to a practice which is independent. That's true.
That has been my anecdotal experience, because remember, an EOB from the hospital looks very different than one that we might
EOB,
see.
explanation of
Yes,
benefits.
sir. Yes.
It's not just the pharmacists who like abbreviations. And so going to that, your site neutral concern that if someone is paying a hospital-based practice, they're going to pay a hospital Part A type bill, which is significantly more than a hospital Part B. So if your copay is 10% of something that's bigger, it's more than a copay of 10% of something which is smaller. So this actually means something to the patient. Everything you're speaking of, to their pocket, to their wallet, it means something for them.
Well, also, yes, because also keep in mind that those bills from the hospital, even if you're moving towards your Part B and you're receiving your infusion in the hospital outpatient setting, I kind of liken it to buying a car. You enter into that payment term over, $5,000 over 60 months. In a hospital setting, you're moving towards satisfying that bigger car payment at a much faster clip than if, they're treated in a community oncology setting. Additionally, and again, it's anecdotal, because remember, I'm not also treating an infused patient at a hospital and my facility. So I can't marry those EOBs together, although I'd love to. But we do hear of patients who have come to us after receiving treatment in a hospital. And, the level of support, financial assistance support, is what we hear is, a value add, which I deem as a required service, not a value add in cancer care, but also that they're moving to that ultimate deductible at a much slower clip.
So let me see here. Got it. Yes, okay. So TJ, Kathy mentioned she has limited insight into what the explanation of benefits would be from a hospital-based practice. I was struck. You knew that Express Scripts for TRICARE charges $3,000 for a drug which is only $20?
Yeah, and that was,
Like, how do you know that, man?
well, I don't personally know it, but that was actually kind of a surprise insight when a pharmacist colleague was helping her mother fill a prescription via TRICARE and tried to fill it at her own pharmacy, and she got her mother's explanation of benefits from what they had been paying TRICARE compared to what they then paid her pharmacy for the one-time fill.
So what Kathy said she would like to do, you were able to actually do you were able to do.
I'll give you a more extreme example. A colleague mentor of mine called the plan himself from his pharmacy to compare, to see why his explanation of benefits and his remittance advice, which is what we get at the pharmacy level, why they didn't match, why there was more on the explanation of benefits. He was charged more than his pharmacy was remitted in payment, and was actually told by the plan that he was not supposed to know that information and was not supposed to discuss it, and he could be kicked out of the network as the pharmacist. Shocking that he was both the patient and the pharmacist, but it's so egregious that much like the gag clause that you helped pass on a federal level, we for a point in time there, we literally couldn't tell the patient that they could get the medication off of their insurance for cheaper, thanks to Senator Cassidy. That's been fixed at the federal level, but these things are so egregious, they almost seem unreal, but they are absolutely real, and they're huge numbers that, those of us that just get stuck with a $100,000 hospital bill, you're stuck in the ether. What do you do? Who do you call? To Ms. Oob's point, I had the same experience with an MRI I needed. It was significantly cheaper to pay out of pocket than what I was going to be billed, and I went to a local independent provider of care, and they were more than happy to do it for a third of the cost that it was going to cost through my insurance. So, those of us that somewhat know how to navigate this world, there are opportunities. There are an awful lot of people that have nobody. So I regularly refer people to brokers. My own mother, when she's trying to select a Medicare plan, I live and breathe this world, but I don't know, especially an Advantage plan that affects your doctors. She really likes her physicians that she's had for years. She didn't want it to change. So I referred her to a friend of mine who's a pharmacist and a licensed broker so that he could guide her through it.
So let me ask you, again, giving us insight into things, I understand you may have an example about a pharmacy benefit manager requiring a mail order for a prescription, but it's not necessarily in the patient's best interest. Can you elaborate?
Absolutely. I had one just this week when a patient was prescribed an inhaler that has a generic equivalent that's very effective. The plan would not cover the generic. The plan required the use of the brand name drug. That's quite obviously because there's a rebate involved there. The generic medication was exactly half the cost of the brand name drug. The patient had a higher copay because it was a brand name drug. I was reimbursed 25% below my cost if I dispensed that medication. I told her to reach out to the insurance company and she could get it for no charge if she used the plan's mail order pharmacy to get the brand name drug. That defies logic for anyone that knows anything about economics, but there's quite simply a perverse incentive there, and the patient is kind of stuck between use a chain pharmacy or mail order pharmacy to get this medication that your doctor says you need, but they won't cover the generic equivalent that's very effective.
So let me just say this. Each of you has been an advocate. Debbie, you and I have not interacted before, but the other three of you have been. And people wonder how, wait, I'm Jane or John Q. Public. How do I interact public policy in Washington? Each of you have. Just a couple examples. TJ mentioned the no gag clause bill. When a pharmacist from Louisiana came from the North Shore, came up and said, listen, Bill, if I tell a patient it's cheaper to pay cash than paying their copay, my contract with the PBM will be canceled. We wrote a bill, got it signed into law by President Trump forbidding gag clauses. And so now there's no gag clauses because a pharmacist from Louisiana came to DC. Ms. Hoob is such an advocate and has recently got access to a database, I'm not sure how, in which she can look at the impact of 340B in each state. And I sent her a list of states, please give this to me so I can share it with the senators who are on the Health Committee. Ronell's been such an advocate for how do we have access for an individual to the sort of specialized care that she or he needs in order to understand the policy they need. Because it's all very nice to say, put it on the internet and let people figure it out, until my theoretical wife and her dumb husband can't figure it out, if you follow what I'm saying. And lastly, Debbie, you may not have been involved, but it was clearly cases like yours that led to the negotiation and the passage of the No Surprises Act. So real life stories makes a difference. Let me continue on that. And some good news, we have passed a PBM reform bill that in the Medicare Part D and I think Medicaid bans spread pricing. I'm looking at my team to see if it includes Medicaid. They're saying no, only Medicare. And then in the commercial space, it doesn't ban spread pricing, but I think it does about the same thing in the sense that it requires 100% pass-through of all rebates. And so if you are charging $2,000 for a $1,000 drug, but then you got to give the whole $1,000 to the employer, it's no longer to the PBM's advantage to be charging a rebate. It's just not. And we think what that will do is migrate people to a fee-based, okay, we're going to charge this amount of money per prescription. We also have other things of transparency in there so an employer can look and say, whoa, I'm paying way too much for this drug when I compare it to what it should cost. So I've been saying we're going to have an informal conversation. That informal conversation will become more formal when all of a sudden employers have access to the true price of a medication versus that which they're paying. I can tell you there's going to be somebody scraping what pharmacies are being reimbursed, what employers are being charged, and they're going to start kind of making those two look a lot more alike. Does that make sense? By the way, there was a pharmacy, a PBM out of Natchitoches at that time called Southern Scripts, now called LaQuinty, which was the one that acquainted me with the idea. And so going back to Steve and his wife, speaking of individuals advocating, they really informed my understanding. So before we go further, I'm just thanking y'all for your involvement. For those watching by live stream, absolutely you can impact federal policy in our country. Somebody mentioned my staff. They are fantastic, and they're going to take your input and pass it to me, and we'll get it done. Let me pause. I don't know if any of you have a question for the other, because you kind of represent different aspects of what we're speaking of, which is kind of why you were chosen. So, Kathy?
You asked me to, so I did write questions. So my first question actually is for you, TJ. How many of your patients that come into your pharmacy are even aware of the gag clause? And I'm going to do the weave because I have a point.
I don't, probably a very small percentage. I don't know that I always followed that requirement in my contract anyway, because I can't morally or ethically.
Well, now it's outlawed. Now it's
Yeah.
outlawed.
And, so I kind of probably dance in the gray area some on that, but a very, very few, but very regularly we try to catch it constantly. But if there's an option for a patient to pay less, now we do give them the option because some surprisingly choose to pay more to get to the deductible faster, but it should be the patient's choice. But if they can get it off of their insurance cheaper, they should have that option. It's oddly, I guess, a perverse incentive for us because sometimes we actually would be paid more if we charge that, but every independent pharmacy owner I know can't ethically or morally do that. So very few know about it, but it's becoming more and more common, especially with Trump RX and Good RX and different things like that. Our in-house plan is often not only competitive, but less than their copay would be.
And then Ms. Rowell, so like I said, I'm going to do the weave. on something like the No Surprises Act,
Mm-hmm.
was that something you were aware of?
After the fact.
Okay.
This was in 2017.
Correct.
And this happened in 2020.
Correct.
Yes, I am aware of it as, now. But then, all I could think about was living.
Right.
So it was very,
Well, you said so, and the reason I ask is you said something earlier about education is everything, and that is extremely true. And that is
yes.
where I'm trying to get at, Senator Cassidy, is, with the No Surprises Act and the repeal of the gag clause, you've really championed some very patient-forward policy. I worry that there's a lack of awareness. And, the No Surprises Act, I'm aware of it because I remember exactly when it passed, as well as the gag clause. But my parents were not. And my mother recently had an event, and they sent her a full freight bill. And my father called. And he's like, what are we going to do? It's, it's $11,000. And I said, well, Senator Cassidy passed this. And I sent him the email and the law and everything. And I said, you call that hospital back. And you send them that email. And it did go away. But that's only because my father had me. And so what happens to all of those millions of Americans that are unaware of some of these very patient-forward policies that you've passed?
So sometimes the way this transpires is that the insurance company or the provider will send the bill. The patient doesn't pay, and so the provider then takes the insurance company. But if the patient doesn't realize that she should have her episode covered by the insurance, you're absolutely right. She may be paying when she otherwise wouldn't because it would be covered by insurance. And that's a great point, which is why we have these sorts of hearings, because staff put it on the agenda. How do we kind of get out there that you have that protection, because someone may feel obligated to pay $95,000 without recognizing, no, stop, this has been fixed.
Well, that is my point. Is my parents have always been tax-paying, law-abiding people, and they thought they were just supposed to pay it, but they didn't exactly have the funds at that immediate time to pay it. And so they called me because they were scared. And so how many Americans do we, family, friends, that are caught in these issues due to lack of awareness? And I worry about that.
Yes, Debbie?
No, that's very good. Great point. I totally agree with that.
I think that's exactly where the agent or brokers come in.
Yes.
And if you
Say that
haven't-
again, please.
It's exactly where the agents and brokers come in. If you have an agent or broker, the person's going to call and say, I got this bill, and what should I do? And that's the point where we're going to educate them on exactly what the laws are. And do not ever pay. We always tell people, do not ever pay that bill until you allow us to help you. And it goes through the insurance, and it goes through the process. So it's important. Education is, powerful. And we all need to play a role. But as an agent, that's something that we do. We bleed for our clients. We love our clients. We want to make sure that they're not caught in those situations where they think they owe money that they don't.
Mm-hmm.
If I may, I think that's there's an example, and again, in our pharmacy world that comes up, and I think you can make an economic argument for it. We see regularly patients on a fixed income that if it's the beginning of the year and they're in the deductible phase, they simply can't afford, let's use an expensive blood thinner that's very effective that someone may need after a stroke or a heart attack. They simply can't afford the copay. Of course, we try to work with them and find copay cards and things like that. But a lot of times what we see is either rationing, where they try to make it last 3 months, or they just simply don't take it, or they self-medicate with aspirin over the counter or something like that. It's the ounce of prevention argument. What are we then paying? I think we have an idea what we're then paying if that patient has a heart attack and goes into the hospital. So I think there's an economic argument to be made, and it's education. We try to fight for our patients and let them know that there are opportunities, and this is, I'm a terrible businessman at times, and sometimes we just give it away because they truly need this medication and don't have another option. So it is the education. There are an awful lot of people that don't have folks that can help them or a broker that they trust, and they do the best they can, and they take a guess, and sometimes it's catastrophic.
Yeah, we shouldn't have to look for manufacturing coupons and all the things that we're doing to help them, but we have to. Because if they're not gonna take it, they're not gonna survive, and we have to figure it out. And bless you for giving it when they need it, because some people just don't have the money. And honestly, as an agent, if I could pay for everybody's medicine and everybody's premiums, I would. But, because it's heartbreaking, but we just can't. And I'd like to ask the question, Senator Cassidy, is, we've talked about this forever, so I know you know, but why in the world can we search for the price of anything in America except for healthcare and medication?
So a couple things about that. We are right now working on a piece of legislation. One, the No Surprises Act began to put in price transparency. I'm a gastroenterologist, so this image comes vividly to mind. Sometimes you would only tell the person that they were going to be responsible for the cost of the care not covered by insurance. When they're about to have a colonoscopy, they're sitting under a thin sheet with, shall we say, prepared for a colonoscopy, or undressed prepared for a colonoscopy, and you'd give 18 pieces of paper to sign, one of which said you're responsible for anything the insurance doesn't pay. Under the No Surprises Act, we changed that, and so that the kind of estimated cost had to be presented to the patient prior to the procedure, not when they're in their, a birthday suit, but when they're like wearing a suit. And by the way, this is what we think it would cost you. So that's number one. Secondly, there's another piece of legislation we're working on right now called the Price Tag Act. Roger Marshall, a doctor, senator from Kansas, and John Hickenlooper from Colorado are co-sponsors, in which, in a more readable, usable form, hospitals would put forward that which they would charge for certain procedures and that which they're getting paid. What appears to be happening, and there's a Wall Street Journal article about this, a patient comes to a doctor who's out of network, and I'm just going to make up numbers to illustrate the point, has emergency surgery, and the doctor charges the insurance company $100,000. The insurance company negotiates with the doctor and pays them $30,000, but bills the employer $60,000 and tells the employer, we saved you $70,000. No, they did not, because they both knew the final price was going to be closer to 30, but they billed the employer that much more. Now, this was an article in the Wall Street Journal. The question is whether or not it continues. If we're able to get not just what is being charged, but which is being paid, I can tell you there's going to be an industry which is going to aggregate this information, bring it to the employer, and say, wait a second, for your out-of-network charges, this insurer is padding their cost. This one is not. So you may think that you're getting a better deal here, but on your out-of-network, you're paying far more. There's at least some suspicion that insurance companies are keeping providers out of network, deliberately not contracting for them, and it begs the question whether this would be an activity so that they cannot indeed do exactly what I just described, pad the cost of what they're passing on to the employer. So how did I launch into that? We are working on price transparency. Now, secondly, I got a great job. And my job is I get to go speak to folks like you and speak to those who are entrepreneurial. But already there are people who are developing apps in which they have a large language model, AI, scraping all these EOBs that are public to find out if you go here for this procedure, to see this doctor, this is how much you get billed. And so already you can say to your phone, where is the cheapest place to get a routine visit for my daughter's earache? That's already before we've even begun to require the full publication of this information. And so when we say money in your pocket or MVP plan, money in your pocket, the value for the patient is going to come from the private sector using this information which is being put out there. So if, as Ms. Wu points out, if you go to a hospital-based practice and your copay as a Medicare patient is 10% of whatever your charge is, but your charge is higher over here and less over there, then you'll know my out-of-pocket will be less over here than it is over there, if that makes sense. So we think that these tools will work for the commercially insured patient and also for the Medicare patient. You bring up an interesting point about TRICARE, and so we have to think about that too. All that to say, the price transparency by itself is not helpful. The price transparency with the tools to use it is game changing. And you don't have to be uber sophisticated. You can be like my wife and me. We know how to use an app. My wife really knows how to use the Amazon app, I've learned. You see what I'm saying? And so that's the sort of thing that'll get you theoretically the best value. So, yes, ma'am.
May I push back on that?
Yes, ma'am.
In the commercial space, if that is the lowest, site of care to get an MRI, but does that mean then that the commercial insurer will authorize that site?
So there's two things about that. And Kathy, of course, is bringing kind of real life experience to this. If you're paying for it with the money that is pre-funded into your health savings account, you control that money. You see what I'm saying? And so you control it. And so it isn't whether or not they are going to steer you to a more expensive drug or a more expensive facility. You control it. I was once on the North Shore going north on 90, I think it's 90, and there's a big billboard, open MRI, $200. Now that could have been $2,000 to $3,000 to $4,000, but they were advertising open MRI, $200. If you had the money in your pocket for your out-of-pocket, you would say, the heck with the deductible. I'm gonna go pay for this open MRI. So I took a picture of it at the time. And there used to be signs for like eye surgery, $200 per eye. So that said, you would control it. You bring up a good point. If you got a $6,000 deductible and you're paying out of pocket with this mechanism, does that count towards your deductible? And that would be one of our reforms. Yes, if you're paying for it. One more thing I should say, we should all be concerned about fraud. The people who are doing these tools also have a mechanism by which, wait a second, this guy's on the up and up, this gal's on the up and up, this person's a crook. And so they only will let people into their system who they know are on the up and up, if that makes sense. Lastly, because I can tell you that some of TJ and some of your money that you get goes to overhead. The nice thing about it is Apple Pay or something similar, where you would immediately pay. And so instead of some of that money going to processing your claim, it's just going to be deducted from your account. And so you get greater efficiency on the account as well. So we're just, and by the way, I've learned people are doing this. All we're doing is catching up with what the private sector is doing. And so you would get, they pay you $100, instead of $15 of that being for your office overhead, or probably more like $35. Now it would be like $98 will be going to support your practice, and only $2 for overhead. So anyway, that's all good. So Debbie, do you buy insurance for your employees?
The only thing I offer them at this time is a supplemental, a life insurance or an accidental policy.
So you have so few employees, you're not required to.
Correct.
Gotcha.
I have 9 employees.
Yeah, I'm sure you'd like to, but it's just hard.
Yes,
Now, they can go on the exchange right now, correct?
I believe so.
Yeah.
I was gonna say, we need an agent for you to come in and take
Yes,
care of those
of course
people
we
and drink
do.
some coffee.
There we go. See?
Trip to DeRitter.
There we go.
And I can promise you, there's a good insurance company in DeRitter.
And yeah, there are many. But we're getting ready to open another a coffee shop inside Beauregard Memorial Hospital in DeRitter. So that will be the second location. Then we're building our third. So the employees they're growing. And so I would really love to talk to see what I can offer to someone, you know.
We can find you some.
Yeah,
And so let me just back up from healthcare for just a second.
sure.
And let me say on healthcare, the reason that among the reasons it's important to make it affordable for the employer is because you're growing, you're creating jobs. Southwest, DeRitter's lumber mill is closed. You need somebody like you creating jobs for other people. And every contribution someone like you makes helps the overall economy. If you're crushed by healthcare costs, you cannot create those jobs. So it needs to be affordable for the patient, if you will, the consumer. It needs to be affordable for the employer, because once you get to 50 employees, you're going to be required
Correct.
to provide insurance. So we've got to make it affordable for the employer to keep our economy moving. So thank you for being an employer.
Thank you, sir.
I like the way that you decrease the stress in your life after your heart attack. You become an employer who's continually trying to expand your operations. Seemed like a real easy way to decrease
know.
your. Hey, TJ, that lowers your stress, doesn't it? Huh?
I'm
Oh, and I
going
would
to
have
talk to him
three
about
pharmacies.
compounding.
Yeah, right. I would have 3 pharmacies if I didn't want to be married anymore. So yeah, I can attest to how and we do. We provide insurance to our employees. Not only do I want to, I need to be competitive, but it's a tremendous expense, and I wish I could do more. But I think we all hit on something, including you, Senator Cassidy, on transparency, and we preach that all the time. That's the enemy of the big bad insurance people is transparency, because it exposes the true cost of these things. And to your point about saving the $70,000, that's the same thing they do with the rebates, and they have all these employers and HR departments and honestly state governments convinced that they're somehow saving them money, and it's a completely fictitious savings on what they wouldn't spend anyway. So transparency is always the answer, and I love the idea of putting money and decision-making power back in the patient's hands, so they can make the best decision for themselves. They can often spend a little more on premium to lower a deductible like that, or pay out of pocket for something and save money.
Yes, I smile. I've been told that it's always the husband who gets the last word in a typical marriage, and the last words are always "yes, dear." And so I'm assuming that that's apparently in your case, TJ. So,
May I jump in?
yes, dear.
Because we are also an employer. So I looked at this on the way here too in prepping for today. So, we're a small employer, 25 employees. And in the last 8 years, at Pontchartrain, we offer a no deductible copay only plan for our employees.
Oh, you do. You're generous.
We try. I mean, it really is important to our employees. We think it also allows us to remain competitive in the space. But also, I did go back and look, and over the last 8 years, the premiums for an individual over that 8 years have gone up $500. So we have 24 employees participating in the plan. And right now, as I'm paying $1,700 a month per individual.
Per individual?
Yes, sir.
Does that cover their family too?
No,
That's a lot.
I know.
Now, can I ask, are there people, for example, we know that women who can have children probably, now, I think it's illegal to charge them more, but it's going to increase the cost for your whole group. So, because obviously pregnancy is expensive.
So I don't know if it's illegal now, but a year ago it wasn't. And so, yes, we have a majority of women in our plan that are of childbearing age. So yes, we opted into the maternity coverage.
So 1,700, that's $20,000 a year.
Mm-hmm.
So going back to what we were speaking, if you're able to give a $2,000 upfront to a family of 4, and now you have a $2,000 deductible instead of a $10,000, and Ronell said at least it would save you 10%, it might save you more, then that would be $2,000 a year that you would be saving. And you said you have 24 employees, so that's $48,000 a year, just run that.
Mm-hmm.
which allows you to take another full-time or half-time
Yes.
FTE.
Yes, and, grow my program, add more research, trials to Pontchartrain, or do a lot of things with it. But I do want to also mention, it was kind of interesting. I was talking to my 28-year-old yesterday and telling him about this. He is a budding actuary who works for a very large insurer in the nation. And he came clean yesterday. He's functionally uninsured. He has a high deductible plan. He has a health care need that he was talking to me about, and he can't afford his medication. And he didn't want to tell me. Now, we're going to deal with that, of course, but he was telling me about another friend in his pod, so they're all actuaries. And that particular friend had a car accident recently, went to the emergency room, and not out of network or anything, but he has to pay $4,000. So he is putting, instead of saving for his home, that particular child, I call him child, they're young men, is now paying off his hospital bill.
Now, theoretically, he saved enough money in premiums. If he had put it to the side, he could have paid off that bill, right? But most people are not that, even
They're
actuaries
young,
apparently. Yeah.
Right.
they're young, and I wasn't saving like that.
Yeah, and that's the flip. You either have a high deductible and a low premium, or a high premium and a low deductible. And people make that choice, and especially young, I'm invincible, I'm good, I'll just get the lower premium and the higher deductible. But I want to back up a little bit. Didn't the ACA add Medicare for everybody, even men? Did that change?
No Medicare for everybody.
Not Medicare, I'm sorry, maternity. It was the other M.
So young men pay more relative to what otherwise would to cross-subsidize, if you will, the premium for the female. That's on the ACA. I thought they did that on commercial insurance. You're implying to me that they don't.
No, I thought when the ACA was passed, because I remember doing presentations everywhere, that it said maternity is, the premiums included for men, women that are too old, didn't matter, that premium was factored in there. And I didn't know if anything had been changed, but that does affect the bottom line.
It does. Yes. So, but, yeah. Anyone have anything else?
Can I ask a question of your thoughts on the 340B program? Because that's kind of a hot topic now, certainly in the pharmacy world. It's hyper complicated, obviously, but you obviously think there needs to be some reform.
I do. What would you like to know?
Well, I mean, are you a fan of the overall program?
Yes, yes, please don't misunderstand me. It is, a vital, I'm sorry, I'm always going to do that. It is a vital program in its original intent, but it is my opinion that program has grown without, lack of transparency and guardrails. And I don't see tremendous benefit to the patient at the end of the day. We've been doing this for 20 years, and I have seen community oncologists and other specialties consolidate into the hospitals over time. The AMA did a study, gosh, it was probably 10 years ago, that when a 340B covered entity can bring in a prescribing oncologist within their four walls, it'll generate revenue of about $1 million annually.
Well, that was my point, that I think it's become a closed system and a significant revenue generator, especially for these consolidated hospital systems. Just to give some brief background, 340B is a federal program that essentially, if a patient qualifies, the manufacturer provides that medication at often a much, much lower cost than it would be commercially available. In our world, it kind of started in rural hospitals so that they could, a way for them to survive. And I don't participate, not because I don't want to, but a lot of times these closed, especially big hospital systems, they won't allow you in their network. their 340B network. So not only are they the prescriber, they're the healthcare facility, the covered entity, and the pharmacy. It generates an awful lot of revenue. And it's kind of heartbreaking for us because that same patient that I was paid 25% below cost, that same entity would make an awful lot of money off of that. So I think it goes back to fairness and transparency, and it's becoming a bigger issue, the 340B
Yeah.
program.
Well, as I mentioned, we've been doing this a while, so we've seen our areas contract.
Mhm.
And there aren't as many as independent physicians as there used to be 20 years ago. But, in addition to that, you mentioned the manufacturer needs to sell those drugs at discount. But there's no reporting requirement on who they're administering those drugs to. And so, simple math, if you're buying that drug at a 40% discount and you get to administer it to a Blue Cross patient and get that spread, I mean, that's significant margin. And that's, if you look more broadly across the nation, we're seeing that with hospital systems like Bon Secours. And I'm sorry, so they are a large health system in Virginia. And they acquired a historically Black hospital, Richmond Community. And what they did over time is they drained Richmond Community of its resources and essentially moved the pharmacy, the infusion, everything into wealthier zip codes. And why would you, of course, do that? Well, that's where your more well-insured patients are. It makes sense on paper. It is not appropriate patient care. That is not a patient-focused way of doing business. And so what it did is it stripped Richmond Community of physicians and resources. Now, you mentioned something about a closed system, and that's something we're seeing also. We are seeing certain 340B entities pass bylaws that will no longer allow hospital privileges to non-340B physicians. And so I have several friends in other states that are now subject to that, and that is stifling their ability to continue to deliver care and bring on new partners. There is a covered entity in this state that is starting to do that. They have not done it for oncology yet, but 2 years ago, they did pass that into their bylaws for 5 specialties.
And so your concern is, I think the concern is just for people who may not be as well-versed in the ins and outs of 340B, is that there's academic data that when 340B is accessible, there's an incentive to prescribe the more expensive medications. And TJ, you referenced that a little bit. And so the person paying a % as a copay would pay more out of pocket, and the insurer would pay more out of pocket because there's an incentive to use the more expensive medicine. If there is a infusion drug of $100,000 and you're getting some percent, say 6% of that, versus an alternative which is $20,000 and you're getting 6% of that, that's one incentive, but the other is that you get the rebate of the $80,000, if you're with me. And so there's a lot of incentives to encourage people to use the more expensive medication, even though the people paying are going to pay more. Ronell, this might be the last question for me, but others are welcome if they have another. During the debate of whether or not to continue the enhanced premium tax credits for the ACA, there's a lot of concern about ghost patients, that people were getting signed up that didn't know they were getting signed up, and the agent was taking a commission. By the way, I always say in every group there's 5% you want to take out back and shoot. I'm just kidding, okay? I'm just kidding. But the point being, there's 5% of every group that is just, that doesn't, that the reputation ruins everybody else. In Congress, they say it's more like 15%, but I'll leave that there. But there were some unscrupulous agents that were signing people up who didn't know they were being signed up. The agent was pocketing the premium. There was a multi-$100 million type of penalty placed upon an agent from either Texas or Florida for doing this. So now we don't have zero premium policies, but I was told recently by someone, an agent, that she was still seeing these fraudulent policies being issued. And of course, I told her to let me know if she has some specific examples. But any thought on that? Because if you have a good program that the federal tax dollar is using to help a fellow American, there's no way to undermine support for that good program if there's widespread fraud. And then the good program is thrown out the window because of the fraud.
I'm so glad you asked me this. I love this question. First of all, I don't call them agents. I call them bad entities because I don't even like to put them in our industry. But CMS is known forever that there's a hole in their system. It allows you to go into their system and put in name, date of birth, and state, which could be anybody. So if you have access to all these people, Jane Smith, whatever, you can go in there and change their plan. So that's there. That's why I was calling for a two-factor authentication. That's happening. Now, the fraud has slowed down some. We have to do two separate two-factor just to get into our systems, but they have refused to close that hole. They originally had that
Wait,
hole.
stop for a second.
Yeah.
We've met the enemy and he is us.
Yeah.
The federal taxpayer is being ripped off because the federal agency will not close a loophole that allows people to conduct fraud?
Right.
Staff, are you taking notes? They're nodding their head yes for the record. Okay, that's great.
So you have these bad entities that are using this hole, and we talk about them getting commissions. They're getting $20 a month. So we're not talking about a huge amount of dollars. Now, if you get bots involved and offshore accounts that we know that are happening, that are turning these people over and over again, then you can make some money. But the average person that you say goes in there and they do it and they made $20, that was not worth their time. But we do know, and we feel that that little hole would solve a lot of the fraud. I mean, there's fraud, rampant fraud everywhere, but that is too easy. And I've said on Capitol Hill so many times, let me put your name, your date of birth, and your state in, and I'm going to show you. And I can't remember what senator was like, no, don't do that. Don't put my name in there. Nobody wanted to see it, but it's true. And it still is true. And it's there. So the fraud is happening. It's not happening as rampant.
But if it's not zero premium, meaning that, okay, I now have a policy.
Right, if it's not zero premium, it's harder to move those people, those bad entities, so it slowed them down. But I personally had one that I sat down with, it was one of my cleaning lady. I sat down with her. She was Hispanic, barely spoke English. We changed her plan, and somehow the marketplace switched her to United Healthcare, and her plan got canceled, and she didn't have coverage for her family. So there's still things happening. It's happening within the system, and they just need to be addressed. And I talk to CMS daily, so I do work with them, and they're my friends, but we just need to figure out how to get them to take action.
Okay,
Did that help?
it does.
Okay.
Now, again, this is very informal. Is there anything anybody in the audience would like to ask one of our panelists? Yes, ma'am. Tell everybody who you are.
Oh, sorry. My name is Dr. Leah Pandell. I'm helping you. I am really excited and happy to see so many people across healthcare, from care centers to prescribers. I think you'll all have. I only have to very from the doctor, as a child, and being $10, and then going to the next year, and being a pediatrician at 50, and then I remember learning about healthcare from that time. So I guess my question for you guys is, which patients knew, reading this or seeing this, that they could take out.
I tell people to get loud. You see something, say something. You don't understand, ask. And I've said it and I'll say it again. If you don't have an agent, call Senator Cassidy's staff. He has everyone that will help you in a millisecond. I've never had anybody call me back and say, they didn't answer the phone, they wouldn't help me. That's not true. They might refer them to an agent or a doctor or a cancer center. But yeah, just get loud. Don't assume that you have to take whatever you get from the doctor or hospital or from a bill.
I mean, I'll add to that from the pharmacy side, and there are certainly good chain pharmacists out there. I'm obviously partial to independent pharmacies. I would say establish a relationship with whoever that is, wherever that is. And if we don't know, which we often don't, certainly on insurance products, we can generally steer you in the right direction. So don't ever assume it's okay to not know what you don't know. And it's hyper complicated, I think, on purpose. But even from the prescriber side, they don't often know what they're sending us, what the patient's copay is going to be, or if it's covered or requires a prior authorization. So we can certainly help most people navigate these things, but it's important to have that relationship so that you can go and ask.
So when I talk to patient groups, I always encourage them to engage with their state and federal officials, identify the problem clearly, but be solution oriented. You know, communicating with your legislators is not meant to be a complaint fest. You know, we get that enough at home from our kids. But they really, Senator Cassidy and, the people that I meet at the state legislature and on the Hill, they do want to help. But very often, what does that look like? And then what does that look like not only for that one patient, but across a broad spectrum? And how do you, effectively legislate? But I always tell them, engage, be solution-oriented, identify the problem, and follow up. And then ultimately, try to grow that relationship to be a resource. And that way, you're continuing that relationship, not just for you and your family, but, for the broader ecosystem.
Debbie?
Do your research.
Good one.
Do your research. It's there. We just have to do it.
I will say, summarizing, lean in. If you're going to go someplace, if you ask for the price, you get a much better price. There's a doc on the North Shore, a physician, and his wife is going for the mammogram. His deductible for the mammogram, for his wife's mammogram, was $150. He said, how much will I pay cash? $98. I mean, but if he hadn't asked, he would have paid $150.
Mm-hmm.
And so, so the key thing is, be forward-leaning. And it used to be that you had to ask for generic equivalent. Now the pharmacist, many years ago, the legislature made it so that unless you say no, give the name brand or prescribe as written, the pharmacist can substitute. So your good pharmacist is going to try and save you money. Sometimes it's built into the system to save money, not always. And you can say, is there a generic for this? Because once I did go out of town, I was in D.C. and they ordered a prescription for me, and I said, "No, this is expensive. This is, I think it was name brand Bactrim." And I said, "You can't give me oh yeah, we can give you a generic," which cuts the price. I don't know what's trimethoprim generic. Pennies.
Not much, yeah.
Yeah, not much. So lean into it, and you can save a lot of money. Like the woman from Texas who stopped me to say, I asked, and now I was paying $600, then less than that, because I was asking, as opposed to just whatever it would have charged me. But thanks for being a healthcare researcher, and the gentleman sitting right in front of you and the woman right next to him help run my healthcare team, and you can check with them to see if they're looking for help. Does anyone else have a question? Yes, ma'am. So going back to the innovation that I've seen in the private sector, once they've scraped and they've found what is the likely price, the doctor then agrees to take that price if you're a member of this network. And so it won't be that they come back in and, oh, by the way, we're going to charge you more after all. Now it's, no, you're part of this plan, and you swipe your card or you do your face view, and that is the payment paid, and it's instantly settled. Now, the doc likes it because the doc is instantly paid, as opposed to not getting paid for 6 months. And the billing is cut out, so they're not doing 20% overhead for all their billing staff. It is like that. There may be a 3% credit card fee, period, end of story, and if that's all that OOBS paid in their practice was a 3% credit card fee, she'll be very happy on that. So I do think we're rapidly progressing to that point. You know, my gosh, if you made 24 phone calls, whoa, that's pretty impressive. I will say that it's never too late to ask, though. So I say that because it may have been the person speaking to you was not the person equipped to give you the cash price. There's a woman who's very active in this space her name is Cynthia Fisher, and she busted her ankle. And so she went to a hospital in Boston, and she goes in and she just is all about price transparency. And so she said, how much is this going to cost me as a deductible? And they said, your deductible is $3,000. And she goes, what if I pay you cash right now? Oh, you pay me cash right now, you write me a check, it's $800. And so you can, even at the last minute, you can say, stop, I want to pay you cash right now. And they'll give you the cash price. Now, if you wait, they're going to charge you $3,000. But if you do it on the front end, if you're the kind of pushy broad that asks 24 questions before she says no, somehow I think you had it in you to ask one more time, because you're impressive.
Yeah, that happens.
Staff, please take a note, okay? Yeah, believe me, Stacy, you just sound like the kind of person who, like Ronell, who just is going to download a lot of information for us from a practical experience. So thank you for that. Anyone else? Mark, you're the youngest guy in the room, but on the other hand, you're a guy, so guys typically know nothing about healthcare. But I'll open it up to anyone else who may want to ask, who just has a real life experience, Mark or anyone else, as regards how is this impacting you?
Well, my family's dealt with some health issues. You know, my father was very young, and oh, thank you. I mean, my whole family's from Wisconsin, so I don't know the interstate applicability here. One of the largest things, and this may be off topic, but it's nonfeasance and malfeasance. Something that very personally affects me and my family is how on the committee do you kind of balance creating, I don't know what the word would be, accountability, and being able to hold, in this case, maybe hospitals, pharmacies for nonfeasance and malfeasance, but also not pushing the envelope and creating a caustic environment to deal business, and as you were getting at, allowing the private sector to flourish. So how do you kind of, in particular with nonfeasance, because where I'm from in the state of Wisconsin, you can't sue for nonfeasance. It's just untenable. No one will take that case. How do you cut that line?
And how are you defining malfeasance?
Well, malfeasance, nonfeasance in the case with my family, it was a physician not taking action.
Malpractice.
Sorry?
Malpractice?
Not in their eyes. My father was undergoing a medical event. They weren't fully aware of what was going on despite what we were telling them, and they chose not to act.
Got it.
For 20 I think, 24 hours.
So there's a couple ways to answer that. First, the malpractice typically is to the degree that would be malpractice, is typically, in fact, it's almost always a state issue. You could argue that the federal government could step in because the federal government is the principal payer of health care now, directly or indirectly in the United States. But there's Republicans who would say, wait a second, the 10th Amendment of our Constitution says that unless something is specifically delegated to the federal government, then that right shall be reserved to the state to regulate. And so the reason that you rightly point out, Mark, what's the interstate applicability between Wisconsin and Louisiana? Because each state has the right to regulate its own, everything that's not covered by the Bill of Rights. And so they would argue that that's a 10th Amendment issue. So it may be that federal malpractice, with very limited exceptions like Good Samaritan laws, will remain a state issue. But you also bring up another tension. How do we attempt to regulate without interfering in the free market? And that's a tension. But the way I look at it, when we buy stocks, the Security Exchange Commission has consumer protections. And those consumer protections keep me from being, what was the term you used? You don't call them agents, you call them?
Bad entities.
Bad entities. That keeps me from being ripped off by a bad entity. Why do we do that? Because at some time in the past, there were bad entities that ripped off a lot of people. When there is someone like a Bernie Madoff that attempts to do a Ponzi scheme, we now have federal protections against that. So when it comes to healthcare expenditures, we can say, wait a second, we're going to pass the No Surprises Act, which takes the patient out of the middle and allows the provider and the insurance company to kind of sort it out on their own, because this is a federal protection of a consumer. Similarly, when we talk about pharmaceutical cost, and we can put in something which effectively is going to get rid of spread pricing by saying that all rebates need to be passed to the payor, which would be the business owner and or the business owner's employees, that is not interfering with the free market as much as putting guardrails to make sure that one party, which has all the information, doesn't exploit another party which does not have that information. Does that make sense? So there's a tension there. As a conservative, I want to make sure that we don't tie our society up in knots over regulations. And I also want to make sure that the people whom I represent are not being exploited because one side has all the information on both sides of a transaction and they can demand any price they want, and I don't know enough to say stop. That's why I think price transparency is getting there. I think it was Ronell that said, every other aspect of our society, gasoline and groceries, you can shop for your best price. A house, you can shop for your best price. The one place you cannot is healthcare. And that's why we've seen costs explode at a rate of inflation far greater than almost anything else. But you put your finger on that tension. Did you listen to what Debbie said from a personal experience? It has changed her experience of how she addresses that. I don't know, but I suspect Debbie, just thinking about this, probably tends to be conservative. I don't know that. But when healthcare touches you, and all of a sudden you realize the fix is in, and you're getting ripped off because somebody can exploit laws that you, as much as you try, and Stacy, as much as she tried, 24 calls, and still at the end they gave her the wrong price. That's when you say, wait a second, the system is broke down. That's when we need to have guardrails. And I thank them both for sharing their personal experience. Now let me just finish with some, usually they give me closing remarks. Did y'all this time, or am I on the wing? They're shaking their head no. Okay.
Wing it.
Memo to self. Thank you all for participating. And thank you for the people who are live streaming, for the people who have been watching. This has informed what we are going to do when we go back to DC to write laws. And it is our mutual responsibility to serve our country. So thank you for taking that seriously, because as I said earlier, each of you has given me things in the past, three of you, because I've never previously met Debbie, but someone like Debbie gave us something on surprise medical billing that has informed us. Today we have more things that are going to inform what we do in the future. and there will be a better future when it comes to price transparency in terms of the guarantee of the ability to get a cash price because of that, because of things that were said here. So for any senator who wishes to submit a question for the record, you have until close of business in 10 days, 10 days from now. Seeing that there's no more questions, with that, we adjourn. Thank you.